I know how.
Look at Steve. You are the man, Steve.
Just keep it quiet on Jonathan. All right, so we'll call the meeting to order and start with the Pledge of Allegiance.
Okay, great. You can stay. Stay.
Of the United States of
America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, Pete. Good boy. Good boy, yes.
All right, so the minutes got emailed out with the agenda, so we've all had a chance to review it. Can we get a motion to accept the minutes from February?
I guess my first question is, do you like that? Is that format work for you? I mentioned last meeting I wanted to try a new format. I thought it might be easier to locate things. And Jonathan, the only thing that was suggested is we need to number the pages.
Yep.
But does that work for everybody? Has anybody got a problem with this new format?
I like it. I say I liked it.
It's just when you're looking for something.
Makes it a lot easier for you to do.
All right, motion to approve. Second. Second. All right, all in favor? Aye. Any opposed? Moving on to correspondence. So the DOH enforcement list, I'm told there is not one.
There is not one. There are none.
Statewide, I guess we've done pretty good.
No, I think it's a lack of staffing to process them through, unfortunately.
Be optimistic.
Huh?
Be optimistic.
That's right. Don't shoot down. Come on.
It's a lack of staffing.
All right, other correspondence. First is we received a letter from Robert Meyer resigning his position on Remac. This resignation is due to him taking another position outside of our region. So congratulations to him, and he is off. Next piece of correspondence we received was approval from the state for Lewis County Search and Rescue to transport patients with blood running.
Congratulations.
So, congratulations. Good luck. We also received notification from the state's approval for Carthage Fire Department BLS first responder. So they will be helping them out. And then last, we received notification for Dr. Capone is retiring as medical director for his agencies. Kevin, sorry. He was medical director for Lorraine Fire Department and Rodman for their public access defibrillator. So those are in the process of being changed over, I'm told. And I believe that is it for correspondence.
Yes.
Moving on, old business, state EMS meetings.
Nope.
Debbie's not here, so we'll miss that one. Diversion. Don't have anything to report on that.
So there will be a meeting April 5th at the FDR-HPO offices. So if you are involved in a diversion work group, you should have received an invitation to that. And we will just be presenting the findings as well as the approval of funding that we've received for 1 year of the EM resource, and seeing if the committee is, we're hoping that all the hospitals will be interested in trying the program for a year. So that's what the diversion meeting is on.
Okay. And then the fentanyl and ketamine advisory, I know that all got passed around a second time.
That is completed, and via email, all the physicians agreed on it. It will be going out. I was going to try and get it out today, but that didn't happen. And again, it'll be going out with strong language that this is an advisory. It is not a protocol change. It is just to help give some clinical guidance to folks who are administering those medications.
Okay. The BLS CME requirements.
So the plan is to initially start off with getting all BLS providers online by the end of the year, kind of like we phased in the ALS. And then hopefully by the June meeting, I will come back with some templates for approval at this body.
And then finally, the PCR memo.
That was completed as well, and I will be sent out with the fentanyl and ketamine advisory. And I've been discussing all of these at county meetings as I've been at county meetings. So,
Other old business? Have anything they want to bring up? All right, moving right along. Program agency reports. Tabbing in.
I'm going to start with Spring Fling. Okay. Do you want me to do my report, or do you want to talk about Spring Fling?
I'm in need of a second lawyer for the mock trial. Unfortunately, that is spring break week, and we now talked to, Bob talked to Luann Mosier. That's 6 lawyers now that are not available because they're, so don't get arrested that week because there may not be anybody to come to court with you. Everybody is going away on spring break. So if anybody can put me in contact with a lawyer, I need a second one for the mock trial, and we have quite a few signed up for that. And so I'm in need of a lawyer. So if somebody can think of one, please text me, email me, send me smoke signals, something, so I can reach out and see if we can find somebody, because we're getting down the wire here and I need I've got a civil and a criminal case that I chose. So we got to get it going. I got to get them in contact with Steve Sheehan and all that stuff. So.
All right, so the numbers for Spring Fling are
We
for...
have 187 people registered and 12 vendors.
So it doesn't seem like our vendors are coming in as fast this year. So we'll be kind of working on that to see if we can get more. Again, being that it's spring break week, it's hard. So.
Anything else?
It's really...
Okay. The modalities report?
All right. So all the rest of this will be in my PowerPoint, so I'll just run through it. So I attended the RSTAC, which is the new stroke advisory committee for the region, and the RTAC, the trauma advisory committee, on March 16th, as well as I participate in monthly quality calls with SUNY Upstate for stroke. I was placed on an EMS committee, and Dr. Gray has joined the committee as well, to look at different stroke scales. So while New York State teaches the Cincinnati Pre-Hospital Stroke Scale, that's a great scale to, and should be utilized, that allows providers to recognize a stroke, but not necessarily the severity of it. So when you get into some of your other stroke scales that are out there, and there's a lot of them out there, that can help identify the severity of the stroke and, potentially maybe the need to go to a comprehensive stroke center. At the last state meetings, we reported on the DOH is looking at kind of changing the way they do accreditation of stroke centers, the same way that they did with trauma centers. You know how they moved the accreditation over to the American College of Surgeons? I think they're going to do the same thing with stroke. That's a work in progress, so that was discussed. And I'm not clear myself whether it'll go just to whether the hospital's accredited by DNV or whether they're accredited by JACO, and they'll follow there. So I don't know if one or the other is going to be the gold standard. As always, they have different levels of stroke centers, so I think you'll start hearing some new terminology and some stuff surrounding that as the state decides how they're going to move. Again, there would be an implementation period of a few years like they did with the trauma centers as the American College of Surgeons took over the verification for those. I put ASAP in and it should have been S there, sorry. Highlights of the 2018 International Stroke Conference were reviewed, and then the next meeting is June 22nd for both RSTAC and RTAC. Some of the highlights that they had from the International Stroke Conference, and the one in particular I wanted to bring back to this body, and that the stroke centers, as they're reaching out to the facilities, will be talking about. But one of the recommendations is utilizing TNK as a single bolus is as effective as utilizing infusions of TPA. I'm sure there's some circumstances around there, but this could help move patients to stroke centers quicker. So it may help the transport portion of it, where they don't have to wait for an infusion of TPA or find an agency that's able to transport a patient on TPA. So that'll be some new stuff that you may be hearing through your facility, but I think it could make a huge difference in some of the issues that we see surrounding interfacility transports of stroke patients, and help them, with the timeline. Because it is, especially for our folks in St. Lawrence County, not so much in Lewis, because they can go to Faxton, but in Jefferson County going to Syracuse, but for most everywhere in St. Lawrence County, you're almost pushing a 2-hour mark to get to a stroke center. So that could be helpful. And they also, at the RTAC, they reported that 100% of the burn patients have been arriving hypothermic at the burn center. So it's something to really be cognizant of, and that's both seen and interfacility transport. So just something to keep in the back of our mind when we're transporting burn patients. So I've had multiple agencies, some we were aware of, some we weren't, have requested BLSFR paperwork. So Messina Fire Department and Brownville Joint Fire District, they both had previously requested it, but we have not received it back. A new one is DeGrasse Clare South Russell out of St. Lawrence County. They were interested in getting their ambulance back on the road. They had surrendered their certificate of need in 2014. So we had some long discussions with them. I have provided them with all the information regarding the process to get a certificate of need back, and highly recommend that they do a BLSFR and sent them the paperwork. And Cape Vincent Fire Department also requested paperwork for a BLSFR, so that has been sent to them. And as noted in the correspondence, we received a BLSFR agency code for Carthage Fire Department. Not a lot of regional adjuncts. We did get a syringe epinephrine notice from 3 Mile Bay. And did we get Canton's? Did we get yours?
Yes, but we didn't get a new medical director form.
That's right. We're waiting on a new medical director form. We have a couple other ones that we're waiting on a new medical director form, which will be reported in the next one. And again, we don't have to approve those. They're just like the PAD, where I give you notification of them, or the public access defibrillation, which we didn't have any since the last meeting either. So previously approved, we are still waiting on Cape Vincent Ambulance's limited lab license, Carthage Fire Department lab license, and Waddington Rescue. Moving forward, as we approve these, I think it would be beneficial that we put a timeline on them, because we've been waiting for one of those lab licenses for quite some time. But again, they should not be performing blood sugars until they have that in place. I did a partial ALS inspection at Seaway Valley, and we'll be completing that at some point. There was nobody available to let me into the ALS medications to go over all of them. As always, there's a huge list of, or the list of all of our EPCR agencies. The one thing to take note on that is, actually, there's nothing new on that to take note of. So the EPCR 5136 forms that we've talked about in the past, where agencies can either go ahead and get theirs submitted now, or if not, when they renew their CON, they will have to submit those, as well as when the state moves and each vendor moves to version 3 of the NEMSIS system. So right now, we had agencies that were very proactive and moved ahead. Canton, Cape Vincent, Guilfoyle, Parisville, Triton from the last meeting. And now Henderson, Norfolk, Alexandria Bay, and Town of Watertown Ambulance Service have submitted the 5136 forms. They've been endorsed by the region from previous endorsements and approved by the state. And the New York State Image Trend Bridge training was completed, 3 sessions with 26 attendees. So that was 1 session in each county. And the state came in and did that. Here's the list of folks that have not turned their paper PCRs in a timely manner. So we have Turin. We have not received July through December of 2017. So again, we have to try and contact them. They receive monthly letters in the mail stating they've not been compliant, and this is reported to the state on every quarterly report.
Are they a BLS or an ALS?
They are BLS. J.S. Coster, November and December. Did we have, with Turin, did we have this year's?
Yep. We've gotten January and February, just not last year.
Just not last year's. So J.S. Coster, November, December of last year, January and February this year, Redwood, August and December of last year, and February of this year. Richville, they are in ALSFR at the AMT level. We don't have January or February of this year. Seaway Valley, usually Dave brings them to the meetings, and I haven't seen them, so I don't have January and February. Hammond, February. Madrid, Russell, West Leiden, I have not received February PCRs for.
I think that if they're an ALS agency and they don't get them in, we should suspend their ALS privileges. They sign a form saying they're going to comply. You're wasting time sending a letter every month, and they're ignoring it. So if they have the additional modalities that we approve for the region, or they're an ALS, time to play hardball. It's ridiculous. What good is it for you to send a letter every month if nothing's happening with it?
No, you said majority of
Wanna
those
go
were
back to that
BLS.
They're
Who suffers the patients?
they're all BLS except for Seaway Valley. Hammond is an Hammond, Madrid, Richville are AEMT level. Seaway Valley is paramedic.
But they all have to have some form of modality, don't they? I mean, they all have AED
Yeah.
or something.
Mm-hmm. Well, so it's the Remac, it's this body that approves any BLS agency to be able to utilize or to do defibrillation.
An epi?
Buterol and all that stuff.
Yeah.
I think when this happened before, historically, you always reached out to their medical directors first to have them step in, and I think that there was improvement after that. Am I recalling that correctly?
In some agencies, we have done that. I mean, I can reach out to them.
Versus suspending them, then,
Yeah.
like in that,
Because
get
if-
the medical directors.
Yeah, if we suspend them, it's who are we really hurting? I mean,
Right.
that's large swaths of St. Lawrence County.
So
would be
are
just
they
out.
not, is there no PCR that goes to where they're transporting, or is it just PCRs that come here?
So all of these folks are still on paper PCR,
Right,
and one copy goes to
the hospital.
the hospital,
Right.
and one copy is supposed to be sent to our office, and then they keep the original copy.
Right.
This has been an ongoing battle for years and years. They're supposed to be, the paper PCRs are supposed to be mailed to our office
Right,
by the
right.
15th of the month, and we've battled this for years.
I'm just wondering, are they doing a PCR and they're giving it to the hospital, but
They are doing them.
here?
They're doing them, they just have failed to send them to our office.
Well, that's, I guess one would be worse than the other, but yeah, it's not good. Doesn't allow you to.
Hey, whatever our office does, it's up to this body, so.
Right.
So I think reaching out to the medical directors is a reasonable approach, because again, if we just say, yep, no, you're not allowed to run calls anymore because you haven't reported.
That's unreasonable.
It's unreasonable and it's unfair to the community.
That's right.
But it's not fair to the program agency every month to contact the same agencies every single month.
Well,
Agencies are abiding by
At
the
what point do we
rules.
say, you know,
There's a,
well, you have to give the director a chance, and then you,
And then
you
we
can,
can put the hammer down.
you know,
That's,
determine what
we're
to
not,
do.
we're not saying we're not going to do anything, but we're going to take a reasonable first step and then save the hammer for if they don't comply.
I would also add that three of those agencies on there, when they're delinquent, and my office knows about it, the EMS office knows about it, I reach out to the ambulance captain and or chief, and then I also, if they're fire-based, also reach out to the fire chief as well, just to kind of put them in the loop and make them aware that there's a situation going on.
Do we, I know we copy him on CON renewals. Are you copying the county coordinator on the PCR? Okay. We can start copying the county coordinators on the PCR as well.
And that would be 100%, you know, fine by me, because I do reach out to them. I get the same thing from OFPC on the fire side when they don't submit their fire reports as well. And what I'm looking at up there is exactly what I see from OFPC side as well. So it's just, it's global for the agency anyway.
Is it worth putting the medical director on the letter?
When we send it out originally.
When we send it out originally.
I don't see
Definitely.
where it would hurt, and it won't take any more time to do it.
Yeah, we can mail a letter directly to, some of them, we don't have emails for all of them, so, you know, some of them are family physicians and et cetera that we can certainly mail to their location.
And put a line in there that's something like, if this isn't rectified, you risk losing your regional add-ons. To put a little kick behind it.
Give them attention.
Do you give them a deadline though before the next meeting, or do we just say, well, we'll kick this can a little bit further? Do we send it to the medical director and say, hey, you know, if you don't get a reply from them in like 30 days,
Yeah, 30 or
if we don't
60
get any reply in like 30 days or 60 days or whatever, you know, put a time frame on it, then their modalities are suspended. Because I can assure you those first two agencies, Dr. Howland's their medical director, and I guarantee you.
First two and last one.
Yeah, so he's going to get that, and he may light a fire, and if he can't get anywhere with them, then he might agree that, you know, start popping them. But I think you need to put a time limit on it. You can't just say, your medical director is going to be notified, and then, well, you may lose this stuff, or you're at risk for it.
We found
Maybe the next meeting, you know.
we need to put a timeline on most everything, or we just keep
I
dragging it
agree,
out.
it'll just keep getting kicked down the road.
So do we say by the next meeting, which is in June? I mean, that's 3 months.
Quite a ways away.
well, and then my question is, do they just get that caught up, or at the June meeting, do we say they haven't submitted their April ones yet? You know what I'm saying?
Right.
Where do you,
I would say if, at the next June meeting, I think that's reasonable, and then at that June meeting, they have to be current for everything. Like, because I have to be current, Mark has to be current, everyone else has to be current. And granted, ours is electronic, but, you know, Lions Falls has to be current, you know, so you should be current by that next June Remac meeting. And if not, then that's going to be the night that we decide whether your modalities are gone or not.
So what
I think
about,
that's reasonable.
what about ongoing? I think that, you know, I think that's what she's trying, so we get them all caught up now, and then
and then in September, the same names are
I'm
on
gonna
there
pull the
again,
same
'cause they
names in
hit.
Strike
September.
two. Then you don't give them the chance, you know, listen, we can't keep doing this.
What's the expectation?
By the
Monthly.
15th of the month, you submit the month prior.
So I would just add that in to that letter.
It's in that letter? It's in bold in that letter?
No, but with the, and you're not going to be able to continue doing it letter.
We're now finding ALS providers who their privileges lapse and to come back into the system, they have to pay a penalty. Maybe we could start sending these guys $100 bills every time that they're deficient.
Is this a good place to talk about, a lot of the other regions have gone to electronic PCRs and given agencies a period of time to get there, 2-3 years or whatever. Is this a good place to kind of discuss that? Is that something that we would like to see? Because then that goes away. when they go electronic, then the stuff is there. It automatically goes up into the bridge. Is that something that we should discuss pursuing, is giving them a 2 or 3 year period to become electronic? With the image trend and the work Ann's done with Coverdale, is that the right word?
Coverdale. So I did reach out to the state because I'd had this discussion, and the Remac can make that something for them to be within the region, especially for ALS agencies. Again, when it comes to the Remac, they have it is the Remac that allows the ALS agencies to practice. Whether we could do that for BLS agencies, maybe a little bit more on the iffy side. But again, we do have the right to pursue that if we wanted to.
What's the state going to do? How long are they going to let this kick down the road before they step in? Because those would be mostly BLS services, right? No.
I have not had much luck getting support in the past with some other agencies until they do not run calls for 30 days. And then they'll issue a statement of deficiency.
I don't know. I've always found it difficult to make it mandatory because I don't know their fiscal situations. Do they have the finances to even go electronic? And if they don't, they're still serving a community need. And I think they need to be compliant with the paper standard.
But the nice thing is that all the agencies, and didn't you say that's opening up again?
Yeah, I'll be talking about that here in a minute.
There's funding available to help them do it.
I would suggest...
I'm not involved in that. Is there fees with maintenance?
There's a monthly fee.
There's a monthly fee, so I'll talk more about it when we talk about the Coverdale Stroke Program, but I think that the majority of our ALS services are electronic. I think it would behoove the Remac to require the ALS services because they are giving medication, and we are looking, at data, and now we're going to start to be able to pull some data and maybe be a little more proactive instead of reactive with quality assurance, especially as we move into the NEMSIS 3 data set. And Jonathan and I have come miles along with trying to pull reports from what we were a month ago. So we're going to actually be able to start providing this body with some reports as we move forward, And I think at a minimum we should at least do the ALS. Well, I'd like to see everybody. I agree with Debbie, everybody should be there. But I certainly ask that this body encourage and helps those agencies, because I think that when the state stops printing paper PCRs, it's going to cost them more to buy copy paper and toner than to be electronic if they get on to this Coverdale program that I'm about to talk about. So, and we currently now offer a $2 for all volunteer agencies for EMS charts. It's $2 a chart. $2.25.
So, I mean,
sorry.
Some of these agencies, is it an exaggeration to say that they run 10 calls a month?
Yeah, none of them are big or huge volumes, with the exception of Seaway Valley.
Why is it so dark all of a sudden?
I don't know.
There it goes.
I don't know. I just turned the page. With the exception, Seaway Valley runs a larger. Right? What would you? None of them are large volume agencies.
15 tops out of some of these agencies.
So less than $25 a month, if that. That might eat at $2.25. Yeah. $30 a month.
And if they're fire base, they can. They get a certain amount every year from the towns and the villages, right?
Yeah, I can see one agency on there that would be burdensome to. I mean, there's broke, and then there's that one particular agency that's up there. The contracts in the area wouldn't support that, you know, and also I don't think it would be feasible. I think it would put them out of business, to be honest with you. And that's just being completely transparent. I mean, they have a chicken barbecue just so that they can come to Spring Fling. That's how broke they are. It's bad. But
We're talking about ALS services.
Yeah, I mean, for ALS services, I would support 110%. But for BLS services, on that list right there, if you mandated EPCR, it would go one of them right out, and that's a large area.
So I think then, at the very least, we need to solidify when we need them current. So I think we're all in agreement that by June 4th, we want all the agencies in compliance. Do we need a motion for that, or it's just
No, because we're just gonna reach out.
all right? And then
Why do you have to wait that long? These papers should be in their hands someplace. So how come to Spring Fling? Take something to somebody. You know, but those papers, if they left them with the hospital, they're the hospital copy. They should certainly have a copy.
That's what I was, that's why I didn't, what I didn't understand. If they're giving the hospital a copy, then there's another copy somewhere.
If they didn't lose them, I just can't, it's something.
Well,
And that's a concern.
Well, that's a
It's a bigger problem if they lost them.
widespread disorder if all those were lost.
That's flat out on.
again, I think it's just failure to take the time to get them together and get them put in the mail to our office. And that goes back to the leadership of the agency, so not letting them come to Spring Fling, then we're actually that's, to me, that would be punishing.
well, and what if they're not sending anybody? You know, they say, oh, cool, we weren't planning on going anyways, thanks. So I think that's, because again, we're also talking about volunteer agencies, and we don't know what else is going on in the background. So
Right.
I think the two month deadline, I think, is reasonable. Right. See, nods of heads. Anyone disagree with that? All right. And then in terms of requirement, what do we want to? Further discussion on that, because I think that's a very valid point, Bob, with the fact that some of these agencies, I think would be a horrible burdensome on them, especially if they're running 10, 15 calls a month.
Right, but why don't you make it a requirement and allow it to be waived with justification? That way you get most, and then those people who are strapped fiscally can write a letter or whatever amount of proof you would need to.
Are we still talking about ALS services or all in general?
Just all in general, because there's only one ALS service on that list, correct?
Well, that doesn't mean that.
Because we have other ALS services that are still doing paper, right?
Yeah, I don't know right off the top of my head, but I think there are a few that are still on paper that are ALS.
Right. And the
They
BLS
just-
side of it, you said was iffy because of the state, possibly.
Yeah. So what I would suggest maybe, and it's just my suggestion, would be within 3 years for all ALS agencies, 2 or 3 years for all ALS agencies, and 5 years for BLS agencies with the ability to put in an exemption for the BLS agencies. That was a good idea.
It's a long time that if we're going to do it, we should just bite the bullet and say 1 year.
That might be difficult because a lot of them, like, I have to do my budget for the next year to get it approved by my supervisors in September.
So 2 years.
So that would give them a chance to budget that, because they're going to need to budget in paying that cost and things, so that way it's not, it can be a budgeted line.
So you would recommend 2 years at a minimum?
I think
2 years
3.
at a minimum.
Yeah,
3.
at least 2.
Because by the time you get it set up and all the training, that takes time. Yeah, I would say 2 years. Especially for ALS services. I mean, if you're giving any sort of drug, you should have they should have the report instantly. You know?
Maybe 3 years for the BLS?
I just made a suggestion, so I don't know if somebody wants to make it a motion or not.
So I'll make a motion that all agencies are electronic within 3 years.
I'll say.
And then they have the ability to do a hardship waiver at the ALS level.
At the BLS.
Or at the BLS level, I'm sorry.
I second that.
All in favor?
Aye.
Any opposed?
And look, I guess we should probably put some clarification. This is transporting agencies, not first responder agencies, correct?
Correct.
We should probably make sure that's clarified in there. That
Yes.
it's transporting agencies and not.
Yes, we do not collect the PCRs from BLSFRs. They are required to have them, they're a legal document, and they have to be on file.
How about ALS first responders?
ALS first responders do have to. So it'll be transporting and ALSFRs.
Yeah.
Okay. Forgot it was me reporting. Got off track. Okay. So CME evaluator agencies, everything seems to be going well with that. There's nothing new there. I haven't had any, so I had 2 sessions in Ogdensburg scheduled that I canceled because I got no RSVPs for one, and I only had 1 RSVP for the other session. So again, I think providers are not getting on board with this process right away, so my plan is to schedule some more sessions after spring fling at the agency there. I don't know if anybody's had any experience otherwise.
Ours are next week. So.
Training, I've completed at Ogdensburg Fire Department refresher for Narcan and and Narcan for Ogdensburg Police Department ×2. I have 1 more upcoming, which I forgot to put on that next week. And again, the EPCR and U trainings, there was 3 of them done. Peter Brody came in from the state and did those, 1 in each county. And upcoming on April 19th will be the Managing Behavioral Emergencies in EMS Environments presented by Dr. Todd Benham. We had originally had that scheduled back in December, and the weather caused us to postpone it. We're going to do a small presentation. We have a small EMS audience and do the presentation at the FDR HPO and attempt to videotape it for others. So, the Coverdale Stroke Program, there's been new life breathed into this. If you remember, it was probably almost a year ago. We got notice, and the program is actually going to allow that image trend, that state bridge, that we have one locally, and we were awarded as part of a larger regional area, including Susquehanna, Mid-State region, Central New York, and us we were kind of called the Super Central Region, and we were awarded the grant monies where they would build us a regional bridge on the backside, and it gave incentives to agencies to get up to $3,000 for hardware and or software for EPCRs. But by the time we even got notice, it was a short turnaround for EMS agencies to get paperwork back to me and submitted for this. But we did have 1 agency that did get their paperwork back, and they received laptops and the initial payments for EMS charts to get them on board for EPCRs. And they will hopefully be coming, they're in their training period for EMS charts. So Susquehanna region actually decided that they were pulling out of the project, so we were in fear that the whole project was going to fail. But it's not. They're still going to allow us to move forward with Central New York and Mid-State. And they've actually assigned Peter Brody, who is the data guy at the Bureau of EMS. And it's moved forward fast since he's been on the project. So they're going to reopen that incentive for agencies, and as soon as I have the information, I will send it out, that up to $3,000 in hardware, you know, whether it be laptops or the fees to pay to start getting the PCR, you know, if they choose to go with another vendor. So it doesn't matter what volume it is. If the agency has less than 250 calls a year, it'll be a flat $250 a year, which is cheap. Believe me, I can. For those of you paying for electronic PCRs, that is cheap. For anybody else who decides to come on and use the Image Trend ePCR platform, $2 a PCR, which again, I know for a volunteer agency that I'm with that runs less than 250 calls a year, that's a deal compared to what we're currently paying now for our ePCR. It will also has the ability to do fire reports. So any department that wants to do their EMS charts and their NIFRs can have it for $250 an incident. So it'd be $250 per documented incident. But that'll allow them to file both their NIFRs and their charts. Again, all of this, the state is, we've been back and forth, and they should be sending out another PowerPoint that we can go through all this and send it out to the agencies and try to get some more folks on board. Unlike the EMS charts deal that we have, this is open to all agencies, irregardless of their status, whether they're not-for-profit, commercial, volunteer, paid, whatever. So that's basically the life that's been breathed back into the STEMI program. This will be the new data set, which all agencies are going to be required to go to. So it's going to be the NEMSIS version 3. So as soon as the state's ready to go live with that, they're saying summer. But again, I mean, our deadline is pushed forward. This will give us some other benefits for the region as well. But they'll have to do a little bit of stroke reporting and look at the stroke calls, as will our office. But we felt it was a benefit to do this because it gives that option to the agencies for a cost-effective electronic option. Any questions on the Coverdale program? We now have weekly calls on this every Wednesday.
90 minutes.
90 minutes. So just making sure everything's in line for this. STEMI program continues to move forward. We're still waiting paperwork for some agencies and the DigiCerts through Healthy Connections, which really the Healthy Connections portion of it's been a huge holdup. There's other avenues out there that we're kind of looking in to see if we can make this simpler. We have hired Amanda Slate. We had some leftover grant monies that this will be solely her focus, and she's a contracted person to help move this forward. I don't think I have to talk to this group about the benefits of transmitting these, but we seem to have trouble getting that technology and getting that happening within our agencies. Some of the newer monitors have that capability, which is absolutely awesome. You know, and I know like for Lewis County Search and Rescue, they're new monitors and they can fax into Lewis County General, but the other agencies can't. You know, so trying to get it where all agencies have the capability. And I know this does, I don't think this affects us much, but the some of the regions had the physio control modems that cost a lot of money to put in, and now they're having to upgrade all those modems because Verizon is not going to support the, I think it's the 1G network, 2G network that they're on, which has become a problem. I know like Central New York has a lot of them that they're now all going to have to be replaced again at thousands and thousands of dollars. Hence the reason why we're trying to go this other route and not buy a proprietary product to be able to do this. So here's just a few miscellaneous things. We did resubmitted to Blue Cross Blue Shield for another Stop the Bleed grant, trying to get the training equipment. And we also worked with FDR-HPO to submit a grant inquiry. We called it Operation Lifeline, Advancing and Sustaining Rural North Country Volunteer Emergency Medical Services, to try and find some assistance for these agencies in meeting paperwork and submitting their PCR deadlines. Meetings, there's a whole list of them there. I attend the advisory board meetings in all the counties. Lewis County, I haven't since, I think Lewis County's meeting was that before, I think it was before our last one, but it's this month. Our TAC, our STAC, Paramedic Advisory Program meeting, just some of the meetings that I attended. Completed our voucher, and the quarterly report will be completed this week. The other thing that I wanted to put up here so that you could see is the opioid overdose program, and as we bring new people on, and I would say that I believe we're out now, this is the type of Narcan you will see out there by first response agencies and some BLS agencies. It is 4 milligrams and 0.1 milliliter, and it is approved for BLS providers under the New York State protocols to administer this instead of the standard assembly required half in one nostril, half in the other, 2 milligram dose. So, and there's a picture of it, I threw the picture up there just for giggles so you know what it would look like, but this is going out to all our opioid overdose program or any agency who gets Narcan from us. This is the supplies we'll be getting now. So if anybody wants more information on those, but I just wanted you guys to know that you may, especially the physicians, if they report we gave them 4 milligrams of Narcan, it may be because they utilized this in 0.1 milliliters of fluid versus the other. And it is approved for them. So, and I believe that is it. Any questions for the program agency?
All right, moving on to new business, the iGel secondary airway.
So I'd sent that out. We have a list of secondary airways. Actually, it was Dr. Coates who brought it to my attention that this iGel may be a good alternative airway, especially because it gave means to do some gastric suctioning. And I sent it out to all the Remac members, all the information on it, so I would love to have a motion to include it on our secondary airway policy statement for approved recommended airways.
Make a motion.
We have a motion and a second.
Jay,
All in favor?
Jay and Don.
Aye. Any opposed?
That was easy.
And 100% online CME for agencies.
Okay, so, well, I expect no vote on this. I am just bringing this forth for you guys to chew on until June, because I felt it was easier to present it in person so you understood. So one of the things that we look at doing is trying to keep continuity amongst the regions. So Central New York just moved to the ability for agencies, if they participate in the program as written, to do their CMEs 100% online. Okay, again, not mandatory for agencies. It would be up to the agencies. The best pricing came from EMS 1 Academy, and I covered it up. ES1 Academy, and again, I just kind of threw that was their little advertising thing online, where they have 225 full-length courses, 275 hours at EMSCU credit. And they're continuously updating this with new materials. Some agencies may have already moved forward and on their own through the state received approval to do this using this system, or there's another system out there called Target Solutions.
And are you talking relative to regional CME requirements, or?
No, I'm talking to New York State.
Okay.
As it stands now, we've always accepted online for regional. At least I have. So this is the price breakdown that they gave. There is a one-time agency fee, which they said that we probably could have waived. So you would not necessarily have that fee. But depending on how many providers signed on to this program, that kind of breaks down the cost it would be for an agency per provider, which my understanding is that's better than most of them.
I guess I'm a little confused. Where does the regional EMS system tie into this? Because
I'll get there in a second.
I've already done two 100% online CME requirements, and in the state recommendations that are out there now, there's no requirement to loop into the region for this.
There isn't.
You meet X, Y, and Z of the state, and they say good.
Right, so I think I'll answer your question in a second. Give me a second. So basically, where the region comes into this is, as you see, obviously better prices for an online learning platform based on volume. So you could have more folks. So if the region were to basically, this is what the state said, if the region were to sign on with this platform, right, we'd obtain that permission from the DOH. Everything that's listed here would be a requirement. Okay? So again, that's just having these agreements. And so we would hold the contract. Here's where it ties in. We would hold the contract. The region would hold the contract with EMS 1. Okay? The contract and pricing would then be determined based on the number of providers, agencies listed. Obviously, the more folks that you get to come into the program, the cheaper the price would be. Again, agencies don't have to come in, or they may. So that's basically what we'll be doing. North Country EMS, we would poll the agencies, find out who wanted to be involved, and then we would invoice those agencies with payment expected prior to contract renewal and payment to EMS 1 on an annual basis. So we could maintain those prices. So the agency would be paying for the online platform, but they're going to get better pricing if we do it through the region, because we can get a larger volume.
Makes sense. So this is simply a fiscal advantage to our
So, yeah, and remember that unless you get state approval to do 100% online CME, your agency would have to get that approval and jump through and do all that other stuff, where the region would do all that stuff. There would be an agreement between the region and the agency coming on board. That agency would then be, still be responsible for their program. But the other thing that it helps is for smaller agencies that don't have CICs available to them, is the state still says you have to vet this content, right? And I don't know for the ones you did a CIC have to go in for the core hours and say this was good stuff? All right, so the state still wants a New York State CIC to go in and say, yes, this meets the objectives for core content. And this, meets, this can be used for online. So the region would also have that, work with CICs to get the content approved and say that it meets all the objectives. And then agencies, like I said, would sign that memorandum of understanding with us, and they would have to provide a whole new, which we have a templated plan, if they want to be allowed to do 100% online CME. Okay, remember, right now, you can only get 50% of your core and 50% of your additional online unless you get approval from the state. So, again, some of the larger agencies have the ability to move forward with this. Did you guys, I think Lewis County Search and Rescue just did this.
We actually just rolled it out today through Target Solutions.
Okay. So, yeah, it's kind of basically the same thing, but this allows for those agencies that don't have the resources.
The smaller EMS service.
Yeah.
It's, you know, maybe.
I think you're going to shoot yourself in the foot with spring fling, though.
A dozen or less CMEs. I mean, that's the thing is these programs continue to evolve. I think ultimately that you're going to see numbers at conferences like we have in other regions and even the state. You're going to see those probably, you know.
And again, that was our, I mean, yes, we know that, but I think that, I mean, with Spring Fling, you know, we're not trying to make money. We're just offering the program so that people have these available, and we would just adjust either how we offer or what we offer if the time came for that. I think it would be, you know, there are some people that still like, no matter, you could give them, you could just hand them and say, do everything online. They're like, no, I like to go to the conferences. Because I think the thing to remember is you have, you know, some people just like that in person, so this allows different ways.
What's the workload increase on your office?
It should be very minimal. If we have, so there are a couple things. We can either have a couple CICs that volunteer to help vet the content. That's the biggest thing. Or we can, and it looks like Central New York is, and I don't know how much, but, you know, if a CIC is charging, so, you know, the region, then we offset that by the number of providers and put that cost onto the agencies for that CIC to vet the content.
But the agency doing 100% CI or 100% online CME program, I use Target Solutions. It's $50.49.99 a year per person, something like that. You know, we're making a significant profit based off the state reimbursement when we're vouchering. So while I'm all for agencies saving money and banding together, I don't know that a regional program to do it is necessarily it's an increase of workload for you that's completely unnecessary, because I mean Richville pays us annually for a decrease in a subscription price for our program, you know, and at the suggestion of the vendor. So my question is why have an increased workload when these agencies should be vouchering the state for every recertification to cover the training costs?
Again, some of them do not have the resources that you guys have, or the time to be able to do that.
So you envision perhaps additional agencies joining the research program because this would become available to them. They may not be in it right now because they don't have a CIC and people available to keep track of it.
I think right now we see agencies struggle with keeping their providers, with managing their CME programs. I'm leaving it at that.
So how will this help them manage it better?
Because they will have the online tracking and the support of the region to, you know, they'll be in a program just like you have Richville, right? You wouldn't foresee some of these smaller agencies, they're not going to go out and look and, you know, they think this is out of their price range, right? So this will give them that ability.
You're creating a cooperative.
Yeah.
Well, you have a price for that one. Should we go to this other one that Justin and Mark and see if they would do pricing?
So again, at the time, I went off based on the pricing that was given to Central New York for the very same program. Yeah, I mean, absolutely, we can certainly ask, because I'm sure that they'll change their pricing now.
I can shoot you the stuff if you text me.
Target Solutions, CenterLearn, and EMS One are, I believe, the three approved departments.
Target Solutions and CenterLearn are doing
The same one.
now.
They combined.
That's right, they merged.
Yeah, so we use the CenterLearn program through Mercy Flight, and we utilize it for credential tracking, for memo disbursement to the EMS staff, to track, like I have under mine, National Registry template and New York State Paramedic template. And as I'm completing these online CMEs, it'll give me a percentage completion for all my core content stuff, and then a training officer can go in and actually, say I sit down for a lecture with our medical director, he can approve that 3-hour lecture as your non-core content, and it'll all add it up, and at the end I can literally print a spreadsheet with all those classes, dates completed, etc., and attach it with my research stuff, send it to the state, and it was hands-free for me last year. I mean, it was...
How do you make sure that people do the whole class and don't just start the video?
It takes time. You have to be in it for so long, and there's a quiz. So even if you go through, click through it, and get to the quiz, take the quiz, you pass it, it still kicks you back to the content. It says you have 10 minutes more that you have to stay into this content.
Yeah,
so it forces you to be in the content.
You can't get up and walk away from it. It's got a built-in safety to it, where if you just hit autopilot and walk away, in 5 minutes it stops the slideshow. If you drop away to a different screen on your computer, it stops the slideshow. You cannot.
Every so many slides you have to click on still here.
Yeah.
EMS one is the same one.
Yeah.
Because we use both of them at Grove.
See, in the way I look at it, I'm going to poll the agencies, and if they come back and there's absolutely no interest, and again,
I think for Seaville it'd be great. I mean, for the 9 people that we have, BLS providers, they really struggle working full-time jobs to keep their core content up. I mean, it's really hard and cumbersome for them over a 3-year period. So you sit down on a weekend and you can jam out 12 hours.
Especially with the hours decreasing, it'll be easier.
and I think from a regional perspective, what we're trying to do is help those smaller agencies, because we understand the larger agencies that have some staff, that have folks that are managing them routinely, have the time to research this and take care of this and get this stuff done. It's our smaller volunteer agencies that are really struggling with all this. And if we can do a regional program that can help them, at least it'll give them another option. Again, nothing mandatory.
This would make basically an electronic training officer for the smaller agencies that put it on autopilot for them.
And right now, just, from my office and in St. Lawrence County, I get calls galore because in St. Lawrence County, there's only a few CICs. And I just had a provider who she was National Registry, came to the state, came to New York State, got reciprocity, had all her education done for National Registry, and they sent it in, but because it didn't have a CIC signature, it popped back. So I went and I verified all the training, and I signed that. So I'm doing this stuff anyways now, at least in St. Lawrence County frequently, because they just don't have the CICs available to help them manage or teach their content.
Do you think the Education and Training Committee could help vet some stuff there? Would that help?
Oh, absolutely. And like I said, this is the reason why I wanted to present this way and either let you think about it if you want to think about it, or
I guess I'm caught on the fact that we just, not too long ago, just said that some agencies can't even afford electronic charting, and if they can afford this but not electronic charting, and then we're kind of, I don't know, that to me...
Well, this isn't a mandate.
Right, but we just said about adding a cost to them.
Because your training money covers this, your training money doesn't cover EPCR.
If they're invoicing the state. A lot of agencies don't even know that they can invoice the state, let alone, I don't know.
Well,
I guess if they want to do it, good for them, but I don't know.
again, it's an option.
My biggest concern is the workload on your office and what it's going to be. And the other concern I have is what happens when they don't pay the bill.
That was gonna be my question.
And how,
Well, then
you know,
it's,
because you still have a bill that you have to pay, and when an agency owes you $300 and you're $300 short, where's that money coming from to offset it? And I realize we can turn theirs off, but there's still a cost.
all right, so that would be, we'd get the agencies, they would have to pay up front for the first time.
Okay?
So when we make this contract, they would have to pay for the first time. And then we would invoice them prior to renewing the contract, so we would have the money in hand prior to renewing. And then if not, their contract would be terminated.
So what happens? Benevolent fund?
So what happens when they onboard new people and you go from 5 people originally to 10 people? How are you collecting that money? Because your price per participant is $27. So ABC Ambulance starts with 5. We build them up front for 5, and then they add 7 more people. When you get your money from, or when you get your bill, it's going to include those 7 people that they onboard.
I don't have an answer for you.
I think the bigger problem will be is if it goes down. You know how people are. Well, you told me it was going to cost me $27, and now you're telling me it's going to cost me $39. That's good. It's more going the other way. If it goes down, they're going to be happy. But if it goes up,
Right, but I think your 1-year contract will hold you at whatever that cost is.
right. But I'm just
And
saying.
then
You know
moving
how people
forward.
are.
Yes.
You told me it was going to be $27, and now why is it costing
Again.
me?
Well, so like you said, you're gonna.
I just am presenting this. I'll pull the agencies. You guys can think about it. Unless this body says you don't even want me to pull the agencies.
No, pull the agencies, please.
I think you got agencies that need it.
Running a small ambulance operation, this would be a great program. And if you don't feel you can afford it, can't. But I tell you, the work that I put into training and stuff, if I had to come up with $48 myself, I would, to make it that much easier. I really would.
Okay.
I think for your St. Lawrence County would be great. Like you said, you're so big up there, such a large area, and so limited CACs that if that can help with retention, it's a good thing.
All right. Pediatric recommendations for minimal ALS equipment list.
Okay, so based on a previous CQI case that was actually, it was an inter-facility where a department didn't have a piece of equipment, and they loaned them, the sending facility loaned them, which was a doctor's office, loaned them the piece of equipment. It made me think that it's probably a good idea that every ambulance have a pediatric pulse oximetry capability. And while most do, when I looked back at our minimum equipment list, we only require pulse oximetry on that. We don't specify adult and or pediatric, which then led me to look at the 2015 New York State DOH policy statement on recommended pediatric equipment for ambulances, and I kind of went through what was not already on the 800 list and what was not already on our ALS equipment list, and 2 things kind of stood out as potentially that could be needed. And again, I think many agencies may carry these, but one was pediatric pulse oximetry, and the second was a neonate BVM mask. Well, when you look at Part 800, it says that they have to have like 3 different sizes, infant to, of pediatrics. It doesn't specify neonate. Again, many agencies already have them, but I'm not sure that's a standard across the board, and my thought was that those 2 items should be added to the minimum equipment list.
I think it's a good idea. Make a motion to do so.
Okay.
Second. That's an expensive price for Zoll pediatric pulse ox. That's about $600 a piece.
Yeah.
Use the disposable.
I mean, even the
ones.
disposable ones are $10 or $15 a piece, and we have
Yeah,
agencies that are.
I had to replace one on the Zolex, and it was literally for the because the extension got ruined and the adult cable got ruined, and that was like $600. It was expensive.
You can use an adult pulse box, put it on a kid's foot and get the same read. Just gotta tape it to the foot. And, I mean, that was, honestly, it was us. And Fort Drum threw a fit because we didn't have a pediatric, which all of our guys use the adult tape to the foot. Does the same thing. And it's a lot cheaper.
Yeah, but does that have to be approved?
What is that?
Well, taping an adult to pediatric foot, you know,
Does your monitor
is it
manufacturer
been
back that?
investigated that it's
Inaccurate reading.
equivalent?
It's off-label.
Exactly.
It's equivalent, and if a child turns out to have been hypoxic, you know, what's the cost?
My concern is the agencies that are doing chicken barbecues to have enough training to maintain their certification, telling them that they have to buy a relatively expensive piece of equipment for, in some of these cases, the one every other year pediatric call that they may do where pulse oximetry may not even be indicated is...
Again, we're talking the ALS minimum equipment list, not the BLS agencies.
Could you amend that to possibly say, and maybe I'm way off base here, could you amend that to say the ability to monitor pediatric pulse ox and leave it at their discretion? Or do we want to mandate a tool or piece?
Again, these are minimum equipments. If they have a way to monitor it, and again, I guess if I was a director of operations, I certainly, you know, from a liability standpoint, wouldn't want to be, you know, unless the manufacturer said, yes, you can put this toe probe on and it will give you an accurate reading. I certainly wouldn't be comfortable with that. But again, that's up to the agency. I'm just telling you that these are the two items that I thought were important items. I think, you know, having a mask small enough for a neonate.
If I'm wrong, because I'm a little out of the order these days, but can't you buy the disposable adapters relatively inexpensive?
They run about $10 a piece the last time I priced them.
And I mean, you can order, say you got 3 trucks, I mean, for less than $100, you can make your ambulances current.
Then they expire.
And it not be super expensive.
And you got agencies that have 10 ambulances.
All right. Well, Maya has a motion on the table, so.
So the motion was to require for the pediatric additions.
What time, do you want to put a time frame in there on when they have to get it by?
The end of the year.
I mean, I just think if you're going to make, we got to put something in there to see if it.
Budget or stuff.
Well, I just think you got to have something so people will know to vote on it. Are we going to say by tomorrow? Are you going to give them a month? You're going to give them 6 months? What is your thought process on how much time you want to give them to do that? This is April, right? So you say January 1st? Sooner than
So
that?
then it brings it back to the liability on this regional advisory board if something happens to a kid in between them. Like we've lived through the bronchiolitis.
Time limit should be 1 day before your next pediatric hypoxic patient. Be sarcastic.
Well, I think that, I mean, just when we did the recommendation to go to cuffed instead of the uncuffed pediatric, that was we gave till the 1st of the year. So I think it's the ability to monitor pediatric. I agree with Bob with that.
And if it would be interesting to know if you go back to your monitors if they actually, you know, if that's an okay thing. It's not off-label use.
They're going to say it's not because
I think it's off-label.
because they want to sell the.
Yes, they do.
It's just such a huge liability
I think
if
it's
you don't have that
off-label anyway,
available.
though. It's just something
There's
we've
a
always
weight
done.
requirement based like adult, pediatric, and then neonate, so it's by kilogram recommendation right from the CMO. and that's what we use on ours. I mean, we carry both pediatric and neonate disposable, and they're about $15 a piece for the Zoll X series.
Pediatric and
We'll just stick with pediatric right now.
I mean, we use them quite a bit more frequently, but
Neonates.
And again, I understand the concern for financials, but I would say that one good lawsuit will put you much farther into debt utilizing off-label than having the opportunity to plan and, appropriately have the equipment that you need.
I've been in all facets of EMS, volunteer paid from almost curses to helicopters, and I always try to think about perspective and cost, but most importantly, patient care. And personally, we don't take care of pediatric patients that often. And the number one cause of pediatric demise is what? Hypoxia. So, just this afternoon I sat with Justin, I'm the president of Louis County Search and Rescue. Our budget is getting modified because, quite frankly, it's tight. EMS reimbursements stink right now. Maybe somebody else is experiencing something different, but I don't think so. But this is one of those things that I personally don't think that we should let cost factor in hugely. As much as it pains me, I would like to say that because I think ultimately if you're going to be an advanced life support ambulance, you really should have the capability to monitor a 2-year-old's pulse oximetry reliably. That's my opinion.
So we have a motion on the floor to make it required for the ability to monitor pediatric pulse oximetry, and we're putting a time frame of first of the year. Is that
And the neonate face mask, which those are only like $5 a piece.
Do we have a second for that motion?
Dr. Waters already.
I second it.
Okay. All in favor? Any opposed?
Oppose.
Yeah, I'm going to move that one
But ultimately, it's physician goal.
Yeah.
It's the docs.
We don't have a breakdown on how many of these pulse oxes used in the rigs around thing would have to buy brand new equipment or just buy an adapter or a plug-in for pediatrics. Do we or do we not? That's the question.
So I believe, and somebody please correct me if I'm wrong, but all the ambulances either have Philips, Zoll, or physio control monitors that have the pulse oximetry on them. So they do have the disposable sensors that can be plugged right into these monitors. Is that a correct statement? So
That's not a problem. I think I still think it's a fiasco of the CO2 monitoring from a couple years ago that really somebody got paid somewhere in this state to push that in the state EMS, because we had a hospital transport vehicle, and we got rid of it because we couldn't afford to pay a $10,000 for a $10,000 new monitor with the CO2 monitor. And you're talking about people, not in this case, but with the CO2 monitor, we're talking about millions of dollars in people agencies having to buy new equipment to satisfy somebody saying it. And I think if you look back on that somewhere, somebody got paid some good money for recommending that. Now, this is not as much of a problem, but if you're telling me that all of the CO2, the PO2 pulse oximetries have plugs where you can plug in and monitor, that's not a problem. But to force people to buy new equipment is the problem.
yeah, no, it
They were
wouldn't be.
required to have that when they became ALS. That was a requirement that went in a couple years ago, that you had to have the CO2 monitoring.
That was required by a recommendation of somebody on the state board, okay? Now, what I want to find is find all the people on the state board and see what kind of affiliations they have with Zoll, with LifePak and everything like that. Because you're talking about forcing people to spend millions of dollars on equipment that is negligee necessary at best, when, as opposed to pulse oximetry. I'm arguing an old case and everything like that, but as long as we have, you can use plug-in disposable sensors on this, I have no problem with it. But for somebody, okay, now every agency in this North Country has to spend $5,000 to buy a brand new pulse oximetry. That I'm not for. Let's put it that way.
So, Dr. Snicer, are you changing your vote then to 4?
Do all the monitors that the systems have basically plug-in disposable sensors for pediatrics?
What about your AEMT services that may not have a cardiac monitor?
They don't have to abide by ALS.
Well, we do. I would have to look into that, but we don't have to. The equipment list is split out between paramedics, CC.
They have to have it because they innovate.
Okay.
Oh,
So you
yeah,
have to
yes.
have the pulse oximetry.
So AEMT services have to abide by it as well.
Yeah, because
I
that's-
don't mind a pulse
In New York
oximetry. I'm
State,
talking
we
about,
intubate.
do they have to buy new equipment as
No.
opposed to a sensor?
No equipment.
All right, then. I changed my vote
They don't have to have
to
cardiac monitor.
approve.
No, but they have to have pulse oximetry when they intubate.
Right, but that could be one of the little $20 jobs, pulse ox.
Yeah.
No.
True.
All right, so, and the docs votes are the ones that we're counting. So
Yep.
we have 3 and I'll vote 4.
I vote in favor.
So
Okay.
we'll add that to the list. Moving on, standard operating guideline change.
Okay, my computer went to sleep. This one should hopefully be easy. So, and I just didn't get a chance to send this out, and again, I'm just presenting it here, whether you choose to vote on it or not.
No, we gotta get compliant with the law. It's a no-brainer.
Whoops. So basically, when we did the standard operating guidelines, in
your papers on the thing?
Yeah, no, I haven't found yet where I'm going, so. When we did the standard operating guidelines for reporting to the REMSCO, the standards followed what the bylaws stated at that time, and with the change in the REMSCO bylaws, it leaves us for a change of reporting. So what is highlighted in yellow, and I will read, North Country Remac decisions will come to the North Country REMSCO as a seconded motion for approval by the Remac chair or appointed designee. Appointed designee may be the North Country EMS program agency director or another member of the North Country Remac, and North Country Remac shall report to the CMAC as required by statute. Actually, to change to the wording, which is exactly like the REMSCO approved bylaws now. Decisions by the Remac, which I need to put North Country in front of it, shall be reported to the North Country Regional EMS Council. Decisions by the Remac may be appealed by the council to the CMAC as described in public health law. So it's basically just taking out the old wording and putting in the new wording as approved by the REMSCO bylaws. And these are standard operating guidelines, so.
What we had there is, it does not meet law. The two set paragraphs below are right out of the law. So that's how it.
So it's a no-brainer. I make a motion to approve this change.
Second.
All in favor?
Aye.
Any opposed? Remac term expirations and new appointments.
Debbie.
So we had put out the letters or emails letting people know that the terms were expiring. If you remember when we did some with a 1-year term and some with a 2-year term so that everybody didn't come up at the same time. And in Jefferson County, we did not have a BLS provider. Dave Sherman was on under Jefferson County, and we moved him to St. Lawrence County, and his term expired. Roberta Simpson, or Bobby Simpson, who is a basic EMT and an EMD dispatcher with Jefferson County has submitted an application to take that. Janine Gomelia has submitted her resignation, and Paul Barter submitted an application to join so that we had the educator. Jay Gannett was on there, and Joe Bova. So what I did is I changed where it said 1-year term and 2-year terms to the dates they expire, so it'll be easier next year when we look at this to say who's are coming up, so we're not playing that game. For Lewis County, Matt Yelton was recommended. Steve Mana expires in 4/19. Mark Tuttle was on there, and Bob McKenzie. So Matt is the new addition there, and that replaces
Justin, because Justin's term expired at 1 year.
In St. Lawrence County, Jen Hines was added as a BLS provider, correct? She's a BLS?
Correct, and we didn't have a BLS application before, so that was Ken Gardner's physician spot because we had, well, we actually had a BLS and an ALS open.
Mark Devers expires in 20. Melissa Brook was being added as an ALS provider. And to fill out a term for Bob Meyer, who submitted his resignation. We've read that earlier. And then Jim Chestnut expires in 4/20.
So with our standard operating guidelines, in order to diversify the Remac, what we started a year ago and this body approved was a BLS, an ALS provider, an emergency manager representative, and an educator.
And the emergency manager is an ex officio member, non-voting, but they participate and all that stuff. So.
And then because we didn't want everybody's terms expiring at once, that's why those first terms were 1 year when we put out the committee recommendations. So again,
the person who's expiring is notified?
No. I didn't get notified.
So that should be hard. I would recommend that out of courtesy.
well, that was when...
That would have saved me 3 hours. Just showing up for them stuff. Yeah.
Well, again, when you were brought on, it was all posted up there that you had a 1-year term. I mean, this was the same thing that was posted, the same thing I had on my office wall stating.
Honestly, I mean,
so
I think in fairness to the group both here in Ramsco, we're getting much better. I think that's one of the things that Debbie brings strength in being organized, and I think this is good. But perhaps years ago we weren't that great about this. I mean, for example, I myself, I put a question mark. I did my form here. I had no idea when my term expired, and when you just put that out there, I put down 4/19 on my conflict of interest. I think out of the courtesy that it should be routine that that we give some sort of notification.
And again, we're new at this too, so we can make that as a point.
Just as a general reminder, because otherwise you might not even think, well, I'm already a member, I don't need to reapply.
That's exactly what I thought. When that came out, I had no idea that was my position.
Sorry.
No, you're new with this. We're new with this. So I think that,
And again, remember, the physicians are the only voting people on Remac, and these are open meetings, so everybody can still have their voice heard if they choose to attend and participate.
So just for clarification, the 12 people on there are the only actual members of Remac?
Yes.
Plus the docs.
Plus the docs.
Hey, I'll get here for tonight, so leaving out late.
Okay, that's what I had no idea.
Well, you were up until tonight. The new.
I
applied. With tonight, you're still here.
No, we're not going
I applied.
All right, I apologize. I will make sure notices go out ahead of time.
At least it was nice to do that.
No offense to what you did. We all agreed to this a year ago.
Yes.
But I have to be honest with you. With all the meetings and all the stuff that I do, I don't remember what date is what. In
Again,
fairness.
my apology.
I mean, and again, not a complaint, just a statement of fact.
So would you like to postpone this until the June meeting? We get with the people that terms expired in April, so if they want to submit an application, it can be reviewed.
Yeah, because I'll submit it tonight.
well, except Were they already accepted?
I said we already appointed.
If those have already been accepted, you can't really.
Well, this is the first it's being seen.
We're viewing it here. It's got to go to Remsco for.
This is the first it's being seen. If you want me to hold off until the June meeting, we can send letters to the people. We'll put a note in the file that in January of each year, the letters go to people whose positions are expiring. We can put in there what their attendance has been, and they can fill out an application to reapply, and we'll have more people for the positions. That's what we wanted. We wanted diversity. We wanted more people. I have no problem with doing that if you would like.
Yeah,
wait until the June meeting. That's not an issue.
I think it's a great idea the January of every year just to give someone the heads up.
And also we'll give a heads up that because we did not have BLS providers that applied, we put ALS providers in BLS positions, and for those that were put in those positions, a BLS provider would take precedence, again, because we're trying to diversify. But again, back to my statement before, is it really, you know, I apologize. I will put the notification out.
It's as much me.
But when push comes to shove, the only voting members are the physicians. Well, we all bring valuable input. You still have that opportunity. We're not taking that away from you. You can still attend meetings.
Does that sound fair to hold off? Thank you. Is that what you'd like? Till the June meeting?
I think that's a reasonable thing.
Okay.
All right. Moving on. Other new business.
So we have a couple agencies that would like to carry fentanyl only. New York State Department of Health told me that if the Remac felt that that was appropriate, that they carry fentanyl. When I say only, instead of carrying fentanyl and morphine, they carry just fentanyl. And the state told me that they could do this if the Remac agreed to that.
I think that's a doctor ask for more abuse.
Well, and we've discussed this before, and our major concern was the length of efficacy, because if you have a long transport time, you would run out of fentanyl before you, in theory, could reach a hospital, whereas morphine, you would have a prolonged, you would less of it. But
there's also the, and I don't know if every county is experiencing this, but at Samaritan, fentanyl and ketamine are on the advisory list. Like we can't get
well.
Yeah, 4 morphine, but we can get 2.
No, 2 is on it. 4 is going to be, because at Samaritan, the only place they stock 2s anymore is the ED.
The ED, but like fentanyl's on the way out. Like they're withholding it from the OR. So that makes me concerned if you're limiting yourself to 1.
Yeah.
What is the rationale? Why does somebody want just to carry the 1?
It's budget.
I think expenses.
Morphine's cheap.
Yeah, I mean, morphine is like 50
Like
cents.
Tylenol for the same price as morphine.
Usually their justification is they just feel that fentanyl is the better drug, and it's just easier to manage one drug, even though fentanyl has quarterly reporting versus morphine twice a year. So again, I've had 2 agencies that have asked about it. So the state told me to get the Remac's feeling on it. So I would say that you guys chew on that until June. And
so what happens if they can't replace the fentanyl because the hospital?
Then they have no.
But then they're no longer an ALS. They're suspended because they won't be able
then
to
they would have it.
There is a New York State plan for drug shortage replacement, and it needs to be approved by the pharmacists given facilities within a region, and the state would enact that policy. It's a standing.
Well, it's the process that in the process that the Remac would have to approve to move forward with that and work with the state for an alternate formulary item.
Dr. Gray, you're absolutely right. At Kent Potsdam Hospital, our agency, Kent Rescue, just was approved to carry upwards to 400 mics of fentanyl. At that time, when we were approved, Kent Potsdam Hospital had 5 vials in their pharmacy of 200 mics per, or 100 mics per ml, correction, on hand. And the pharmacist withheld that up until approximately 3 weeks ago when they received an adequate shipment. So there are some real concerns about having just one analgesic versus having a couple in your toolbox. But it's also a matter of, in that state plan, when facilities within your region are in such a shortage, there needs to be better communication, I think, from pharmacies to the region and the region to agencies and vice versa.
Again, the only, I mean, there are alternate formularies. And again, the only time I know about shortages are when my agencies contact me. And if I've heard from 2 or 3 agencies, then, I can bring it to this body or look for an alternate formulary.
See, we've been put on notice that morphine was running low from Lewis County General.
It does.
It's like it's the flavor of the month. Like Epi 1 to 10 is this, and it's just, I don't know.
It is. So usually when I get a call from an agency, we work through ulterior purchasing methods. And if they cannot get it from any vendors, I tell them to call me back. And usually it's resolved before we have to go to an alternate formula like we did, although we did go to an alternate formula with Epi not too long ago. And there is a process in place for that. So I guess I'm getting kind of the feeling that this body would prefer that keep both options of that they should keep morphine even if they have fentanyl.
Yeah, I make that formal motion.
Okay. Well, you don't need a motion. It was just a discussion because as it stands now, the only way to go fentanyl only would be with Remac's approval.
Yeah, and I would say we should probably reach out to the agencies themselves that are requesting and just ask why. What is their thought process, and do they realize that these other things are coming down the pipeline?
So,
on the shortage of fentanyl, if we encounter that, we have a specific protocol for post-intubation management care. Is it possible to have an alternative analgesic of morphine when we are without fentanyl? Would that be something to consider?
For the RSI?
Not for
That's
RSI.
routine post-intubation care for all intubated patients. It's not specified for RSI intubations only. The guidelines are 100 of fentanyl followed by 50 every 10 minutes, and midazolam is 5 milligrams every 5, if I'm not mistaken.
Yeah. So fentanyl's 100 mics.
Initially, and then 50 every 10 thereafter, if I'm not mistaken.
Yeah. And then Versed is 5 every 10.
So if we're...
You can substitute ketamine for Versed. I think that's something we should probably discuss.
Just in the presence of a shortage and making sure that we have some versatility.
Well, but also, Mark, always remember, too, you have the option of med control.
That.
If you have no fentanyl on the bus, just call them up and say, hey, this is what I got. What would you recommend for a dosing schedule?
And keeping your
always a
medical
great
director in the loop, too.
reminder. Thank
hey,
you.
Fentanyl's out. What do you want us to do?
So do we do that route versus changing this?
Yeah, you can't change that.
I say I don't
That's
think
a
we need to
collaborative
actually,
protocol.
because no one's actually reported being out yet, correct?
Correct.
So I mean, it's
Keeping your crews
But there's always a
abreast.
medical control option.
Right.
He's 100% right. If you don't have fentanyl, you need an order for morphine. Call him an order for morphine.
Because the dosing schedule is going to be different. You're not going to get 50
Correct.
morphine, or 4 milligrams of morphine every 10 minutes.
But that's what medical control is for. So.
Thank you, Matt.
When in doubt, call a doctor.
All right. Any other new business?
I just want to give you an update on JCC's course sponsorship for the paramedic program. I've been in continual contact with Linda Dietrich, and I bumped it up to Tom Finch, who is the vice president, because we weren't getting responses. And I spoke with him on the 28th, and he said they have a big meeting on Wednesday to discuss the future of it. That letters went out to anybody that had submitted applications to enter the paramedic program in the fall, letting them know by April 15th a decision would be made on the status of the program for the fall, and that he will follow up with me on Thursday of this week. They are going to require a minimum amount of people for the program to work, which is 20, which is unrealistic. It's not going to happen. I asked him if he would provide a letter of support for us to look at using a different course sponsor for the fall to be able to do a program like distance learning. And he will do that if they decide not to. Debbie and I went down and talked with the Herkimer folks, the Paddocks, about doing a distance learning. They were amenable to that, and then we had a call with SUNY Upstate this last week, and they were interested. So I think we have some options so that we can let people continue with their paramedic training, and the fact that they're willing to give us a letter of support will make it much easier for us to continue. So my gut tells me there's not going to be a program. I think by the time if they decide to do it, then they advertise to fill that position. It's a very specific position with the accreditation that you have to have. It has to be a full-time, bachelor's, paramedic, all this different stuff in order for the accreditation to continue. I think that even if they found somebody, by the time they got them online, they wouldn't be ready to start a program in August. We will have more, and I will provide the information to Ann to email to everybody. But I think this is probably the route we're going to go so that we can attempt to have a paramedic program in the fall.
Just a question on that. Is it, and I know it's probably two separate issues, but if there's a possibility of setting it up with distance learning, is it possible to set it up with two sites, one in Watertown and one in maybe Canton?
After the first year, yes. The initial year, because of all the stuff that we have to do, and Andy Johnson has indicated he will work with us to at least get one up. In order to do the distance learning, you have to have a paramedic CIC there during the training.
Correct.
It would be on site.
Yeah, we're aware of that. I mean,
right.
Mark and I have been discussing that regarding St. Lawrence County for a while.
Right. So I think that that's a potential for the following year.
Okay.
I think the first year we've just got to see if we can, to get it up and see if we can get the bandwidth. We've been talking about what in St. Lawrence County might have the necessary bandwidth, and the only thing we came up with was maybe Kinney's in their conference center there, because it's a very specific bandwidth that you have to have. And in Jefferson County, I'm hoping that maybe Dank will work with us and help get it somewhere so that we could get it
What's
up.
What's the typical enrollment? Like how far off is are you from 20?
4 or 5. 15 off.
Is all they've had. 4 or 5 people is all they've had.
Oh.
So 15 people off.
I think the problem with that too is that there's so much unknown, and people don't want to, and that's why they're going to other places right now. Like I got guys that are applying to Herkimer because they don't know if Jefferson County is going to have, or Jefferson
But
JCC is going to have.
the 4 or 5 has been how many years now? That's,
Right.
I mean, people saying, oh, I was going to do it this year. It's just like everything else. Yeah, we hear that, but when it comes to putting the paper, but hopefully this will give us so that we can at least have a program and allow people to.
Debbie, I don't know if it's still here or not, and I'm really, really talking out of school here, but I don't know the bandwidth you're looking for, but I know that West Telecom fiber is in this building.
Is it?
I know it is because we got it here.
Okay.
Now, again, I don't have anything to do with it anymore, but...
What is the bandwidth requirement?
I don't have it with me. I didn't print that. They started talking some of that stuff, and it's like... Okay, yeah. But the state has indicated that they will work with us, and because Herkimer already has been approved for distance learning that they're doing in Onondaga County, that we could perhaps just take that and make some minor changes and get it pushed through rather quickly. But we've expressed to JCC. When did we have the first meeting? Last fall. That you gotta decide what you want to do here. It's not fair to students to. And they have also indicated they're not willing to budge on the 2-year program. they're not willing to.
And we're with you, the uncertainty is not been good
Right.
for any of us.
One thing that could increase their numbers from that is, and I know they never really wanted to do this, but it is a 2-year program. So instead of putting new people in every single year, make it a 2-year program. You can apply every 2 years. If that causes you to increase the numbers, it also allows the people getting out of basic class to get some actual real experience for class students.
Well, when we had a meeting, they brought all the stakeholders in, and we had some folks there that had been in the program and some that had been in the other program, and the biggest thing was, I can go to school 2 years, become a paramedic and make $16 an hour, or I can go to school 2 years and become a nurse and make 30-something. We need to shorten this program. I worked with Janine, I did the whole schedule, I got it down to 15 months, and the college was not willing to accept it. Just wanted to share that with you so that you had that information.
Any other new business? If not, I'll entertain a motion to adjourn.
I'll make it.
Second? Yes, all in favor, aye. All right.
Aye.
Do we have CQI?